Hello, everyone. Good morning, good afternoon, good evening, depending on your countries. I'm Bernard Allemagne. I'm a member of IRCAD and the University Hospital of Strasbourg. And we are very pleased to start with you our new experience with video conferencing due to the current circumstance with this limitation in social meetings that, of course, impact a lot the activities of our institution. So thank you for joining us. We're using a system of video conference. Maybe some of you are familiar with this system. Some of you are not familiar, so briefly, I will just explain how this system will work. So on the Zoom platform on your screen, you have different buttons. And for the interaction with our chairman and our surgical team, we ask you to ask for question, and you have two modalities. Either you can write down your questions and we're checking your questions, or you can raise your hands. You have a button to raise your hands. And here in the technical room, we observe the questions, we observe the hands, and then we will connect you on the platform. And so if you have a video connection, you will appear on the screen and you will be able to talk in your microphones. So you cannot connect yourself. That's here in the central room that we will give you the authorization for the connection. So today we are presenting some live procedures. So it's through live. Silvana Peretta and her team are in the operating theaters of the University Hospital. And today, as you know, probably she's going to demonstrate on the sleeve gastroplasty. And we have the chance to have two famous chairmen today. We have here on site, we have Liz Ranström, doesn't need any introduction. And from remote connection, we have Manuel Galvano Neto, who is also doesn't need any introduction. So we have really two experts that will share this session during live. So I give the ground to these two chairmen. And on my side, with the technical team, we will watch for your questions, your hands, etc., to allow for the connections. Thank you, the chairman.
Thank you, Bernard. And I'll add my welcome to everybody that's along with us, and especially to my co-host, Manuel Galvez Neto. As Bernard says, undoubtedly almost everybody knows him and knows of him. So thanks for joining us as well, Manuel.
Thank you, Lee. It's a pleasure to be here.
So I think we have an interesting case for everybody to see. We'll go ahead and go to Silvana and have her explain what she's going to do and who she's going to do it on, and of course, who's assisting her.
Yes, hello everybody, good morning or good afternoon. I'm very happy to have two fantastic chairmen who are also very good friends, and both of you look very smart today. So thank you for gearing up for me and for us today. You can see on my right side, Margherita, who's going to be assisting me. Margherita is a junior surgeon here, and she's also an expert endoscopist. So I have very good help today and assistance. We're going to perform an endoscopic sleeve gastroplasty, as you have seen on the program, and we're going to do it with the Apollo device, Apollo endosurgical suturing system overstitch. And we're going to use the double channel scope and system. And I will show you first all the equipment and devices that we're going to use, and then we're going to present the patient. So we're using today a double channel Olympuscope because we are using the overstitch system that goes with it. But this device can be also mounted on the single one on multiple single channel scopes. I like this one here, the older version, if you like, because it's very sturdy, it's very secure, allows you really to pick and choose and grab the tissue as you wish, and I'm more comfortable with it. So it's an over-the-scope system, as I mentioned before, that we're going to mount onto our scope. Carlos is our cameraman today, and so you're going to hear his name multiple times. And hopefully he's going to give you a very nice zoom of the tip of the scope. I'm going to give this to Margherita and going to mount the handle of the device onto the handle of the endoscope, just clicking on it like this. So if we can zoom onto the distal tip of the scope, we can see that there is a needle that can shuttle up and down like this and will help us transfer the suture. We're going to now mount the suture on the needle holder, and we're using 2O polypropylene non-resorbable suture. And we're going to slide them, stretch them a little bit to get rid of the memory of the suture like this. They're hydrophilic suture, so I like to dip them in water just before I use them, like this. It will help them slide better into the channel. So I will open the channel with the handle and slide the suture right inside. Always test the instrument and make sure that everything is working before getting in the patient. This is very true for all the endoscopic procedures, because it's not just like laparoscopic or open surgery that it's easy to get back and forth. So we like to have a little bit of a slack, of a loop at the very tip, so that it will facilitate our needle transfer. You also can have the internal image maybe here that you can see. There you go. And you can see the polypropylene suture. And I'm going to test if it transfers it correctly to the needle. So it's really by manipulating the handle that you can transfer the needle. As you can see, this is a very sturdy needle. It's 1.5 centimeter. It gives you very, very, very good grab. And also you have to be careful what you're grabbing, because it could, and that's the aim, go full thickness around and inside the gastric wall. So once we're set to go, I'm going to introduce the scope into the overtube that we have previously positioned in the patient. The patient is lying supine. She is under general anesthesia. She has orotracheal intubation, so you do not need a nasal intubation. Oral intubation is just fine. And this overtube is very particular because it has a, Carlos, if you can zoom, it has in fact a balloon trocar at the very proximal end that allows you, as you wish, to open and close the balloon in order to maintain or undo the pneumogastrium. So you have a better control over your working environment. It's a pretty long overtube that's going to also protect the airways and the proximal esophagus and pharynx. So we're introducing a pretty bulky device. So I would recommend that whenever you're doing this procedure or whenever you're doing something that is requiring an over-the-scope device, especially if you are not so experienced, please do use an overtube to protect the airways. So we're going to go in. And we can switch to the interview. There we go. So I'm introducing the device. And while I'm doing this, I am going to also present you the clinical case. All right. So this is a 49-year-old patient that I've been following up for a while. And she was supposed to be operated right before the COVID surge. So she had to wait a little bit more, but she had the time. She's a nutritionist, actually. So she had the time to go and do her nutritional period and follow up very well. She lost quite a good amount of weight, as you can see in the slide here. She went from a BMI of 40 to a BMI of 36. She already had a first, I would say, experience with endoscopic procedures for obesity, because she had back in 2010 a balloon that was placed and then retrieved because of failure of the device. And of course, being a bariatric patient, she underwent all the preoperative standard bariatric workup, which includes, of course, psychiatric evaluation, cardiac evaluation, endoscopy, of course, and as I mentioned before, her nutritional counseling. So I'm introducing the endoscope inside, and I stopped here because I want to show you something that is very important, and actually something that I learned from Manuel. So Manuel, I like your trick. Manuel always likes to play safe. And the trick is, I'm going to ask Margarita to inflate slightly the balloon. And you see that I can see the lumen of the esophagus. And this is very important because that will allow me a safe, controlled, under the view introduction of the device inside. So whenever you're pushing something into the esophagus, never do it blindly, but also always do it under visual control. Now we're going to release the balloon so that I will have more freedom to operate and freedom to move. And you can have a very good view of the suture here. I'm going to talk a bit about the anatomy here so that you can get oriented. I don't know how many surgeons and how many endoscopists are signed up. So if you have questions, if you don't understand the anatomy, please feel free to ask your question to the chairman and or directly to me as you wish, raising your hand. So what we're going to do today, we're going to reduce the gastric volume by applying a U-stitch shape in order to shrink the greater curve of the stomach, in order to shorten the stomach also. So I'm going to start from the anterior wall of the stomach, starting at the level of the incisura. Then I'm going to go onto the greater curve, and then on the posterior wall of the stomach, then again posterior wall, greater curve, and again onto the anterior wall of the stomach. So it's a U-shaped stitch, continuous suture, then I'm going to cinch. I'm just going to repeat the same thing till the fundus, but sparing the fundus in order to achieve the gastroplasty. Very important is the starting point. Of course, you can push onto the stomach in order to understand where you are. A lot of operators, and Manuel is among them, like to do this kind of procedures with the patient on the side. It's possible. I like it to do it like this because it's more familiar to me being a surgeon, and I like the liver and the gallbladder and the bowel to be far away from the stomach. What you could do is also tilt the patient head up a little bit so that the bowel will slide into the lower portion of the abdomen to make it even safer. All right, we're going to start. I'm going to ask Margarita to introduce the helix device. So this is very tiny. I don't know if you can see it well. It looks like a corkscrew, like a helix, and it's going to serve as a grasping device that's going to help us introduce the gastric wall into our suturing device. And it goes into the smaller channel, which is the one onto the left side. Me lo bagni un pochettino per cortesia che non...
Silvana?
Yes.
To answer your question about the participants, we will send on the Zoom platform a questionnaire, so they just to push on the response and we'll know exactly who is in the audience.
Okay, perfect. On peut baisser un peu les lumières maintenant?
So Silvana, can you one more time just tell us where your distal landmark is, to know where, because you like to spare the
yes.
antrum. So where do you start suturing?
So I start at the level of the incisura, you can see here, or at the end of the gastric folds, or beginning of the gastric folds, if you wish. So really the starting point is very similar to sleeve gastrectomy. It's going to be about 5 centimeters from the pyloric ring.
Thank you.
And you can see very well here, I'm touching it with the scope now, the incisura. Okay,
Silvana,
so, yes.
So this is Manuel. I just going to get back to the overtube. Overtube is very, very safe. This one is so safe, but I just got a publication from Video GIE of 5 centimeters tear on the esophagus when people don't use that correctly as you have done.
Yes, it's true. But well, you know, this is one of the main lawsuits that you have in the United States, Lee, correct me if I'm wrong, is because of inadvertent esophageal perforation due to the introduction of tubes. And so everything has to be done by a physician, the physician in charge of the case, and has to be done with the knowledge of the anatomy. And I would say extreme grace, not just putting it there like that and under endoscopic view whenever that is possible. And that is the reason why when we're placing the overtube, we're really going all the way into the stomach. We are luxating the patient very much, and then we are gently introducing the tube with tactile feedback. If you have a resistance, you stop. So you really have to be used to do that. I mean, all the perforation that have been described with the calibration probes used for sleeve gastrectomy should have taught us a lesson.
Silvana?
Yes.
We have the response to the poll.
Yes.
90% of surgeons.
Okay, good, great. So Margarita is going to release. All right, so we were busy discussing, but I just want to spend a few seconds describing the device that Margarita is using, because this device is really trying to fetch the, here it comes, a full thickness grab of the stomach. So she's going to get it out. And here the stomach is a little bit thicker, so we can go in 3 times. 1, 2, 3, as Manuel would say, 1 for you, 1 for me. And it's very important to bring the tissue into the jaws. So I'm gonna move my device to make sure that I'm grabbing the tissue really perpendicular to my device, so that I'm sure that I'm full thickness and I'm sure that the suture is gonna transfer. If I grab too much or I didn't grab well, actually, the needle is not going to go through properly. So you can see here that already we have 3 bites, and we're cruising along the greater curve in order to aim posteriorly.
Silvana, since the helix grasper is probably long enough, it looks like it's about 6 millimeters long to go full thickness. How do you control it so it doesn't fully perforate the stomach?
I think it's both. It's mainly a visual feedback. You have to stop when you start seeing that the tissue is twisting around the device, because it means you went through and through the gastric wall. So always pay attention to the visual clues, and then it's pretty safe if you use it correctly, actually. So I'm going to just turn a bit so that I can grab posteriorly.
Yeah,
okay.
I really like this particular maneuver, Silvana, because now you're facing perpendicular, and also
Yes.
you turn your body, and the people that are following with us, you can track the suture that is the suture never crosses, and this always is very we have to aim and have to be in mind, as you are doing beautifully here, is that is a surgical suture line. So it's not like any random, you cannot just throw up random sutures, otherwise you're going to trap yourself.
Yes, and if you trap your needle, it's a little bit tricky. So here we are ready to start going back. And this suture is very important not to tighten it too much, because if we tighten too much this suture, we're going to create a hyperpressure system that's going to weaken all the sutures that we're going to place afterwards. So how to teach this? I like to say that we have half of the circumference of the incisura, like a half moon or raising moon if you want. And that is good enough for the first stitch. So I'm going to start going backwards. Okay. And always work far from the stomach wall and bring the tissue to you. Okay. Margarita is so used to this procedure that I don't have to tell her anything. She's so good now. And what she's doing, I don't know if you're noticing it, but she's only exposing the helix. Once I'm past, can you retrieve it? Just once I'm past the suture, because if she exposes now, I can grab the suture, I can trap the suture within the device. And that is a little bit cumbersome to fix. Me and Manuel, we had all sorts of problems. So I think we are masters in troubleshooting. And also
Yes.
Lee, who has been one of the pioneer in using this device.
Silvana?
Yes.
We said another question about the experience in endosleeve gastroplasty.
Yes.
30% of the participants do have some experience.
That's very good.
Yeah, 70% no experience.
Very good. So this is nothing new for a few of them, but I'm sure that they can ask some question or, right? Okay, so here you got to be careful. Okay, so we are ready to release our first suture. And in order to release our first suture, I'm backing a little bit off like this. And I'm going to release my thread. And I'm going to get it ready to cinch. Now, pre-cinching is very nice because it allows you to gain some time and really to tailor and see how you're doing. And you're also avoiding to put too much pressure onto the cinching device that we're going to introduce.
And it's very interesting, Bernard and Silvana, to see that 30% of the audience have some experience with endoscopic gastroplasty, because it's gaining popularity, because in the recently past, it was 95% didn't have experience. So it's good to hear that.
Yes.
This must be almost your 200th case, Silvana.
Yes, yes. So if I do something wrong, you can blame it even more on me. So now I'm ready to cinch, and what we do when we're cinching, we are pushing and pulling till we really have the tissue coming nicely together. You don't want to cinch putting too much pressure because you're going to break everything, and you don't want to cinch when the tissue is not together because otherwise your suture is not going to hold. You can ask your assistant to hold something for you. I like to do it myself. I always say that women are better placed to do this because of anatomy. But it's something that the more you can control yourself, I think the better it is. So Margarita is going to release now the little plastic tip that's going to secure the suture. Now, she's being very gentle doing that because it happened to me already 3 times when I had a big man helping me that wanted to demonstrate how strong he was. And Manuel, you witnessed one of these events, that he crashed so strongly
Indeed.
the device that we got stuck into the stomach with the cinch. So you need to have a very big scissors in order to undo the metallic tip of the cinch, and then piggyback it all the way out on the scope in order to release the stomach.
Silvana,
So,
Silvana and Chairman, we have one question from the audience. What's the difference between this procedure and pause?
Manuel, that's for you.
Yeah, yes, thank you. That's a very good question. Here, what you see Silvana doing is suturing. So she basically is doing the suture as we understand the suture is. In pose, what we do is plications. So you have a bigger corkscrew like grasper, and the jaws of the instruments are 6.2 centimeters. You can have a 6.2 centimeter fold, and then you pass a gigantic needle into that, and you deliver a basket in one side, a basket in another side. They are made of nitinol, and also the suture that gather them together are made of nitinol. So it's a big giant fold. So actually you enfold tissue instead of doing the suture line that you see in Silvana. The pose 1.0, the old pose, the one who failed in US, it was done in the fundus and something in the antrum. And now everything is changed, and they are doing what they call pose 2.0, the basic mimic what Silvana is doing, working on the greater curvature. This procedure is actually under FDA scrutiny. In some countries in Europe, they are like allowed to do it. And the difference that instead of tubulizing the stomach, as you're going to see children doing, they shrink the stomach like when you put your feet over a Coke can in that. So that's the main difference. They seem to have similar weight loss, but about durability and adverse events, we don't know yet, because the post 2.0 is very like early, in the early phase of development, different of what we have here in endoscopic sleeve gastroplasty, that we have more than 5 years of experience.
The other difference with the pose is that it uses a special endoscope, or not really an endoscope, it's a pediatric endoscope, but it has a large delivery device that's proprietary, because the suturing device is 4 millimeters in diameter.
Mm-hmm.
Indeed.
So I just want to attract your attention here. So I'm really posterior now, and the needle is very big. So what I'm doing, I'm gently just biting delicately with the teeth of the needle, and I'm going to lift up. So I'm creating a distance between the posterior wall of the stomach, the pancreas and the celiac trunk and the splenic artery, everything that can run into this particular site. And this is, I think, in my opinion, very, very important. So knowledge of the anatomy. One of the questions that a lot of times I'm asked, how do you know where you're placing your needle? Because of surgical anatomy. That's very easy for surgeon. It's a little bit more tricky for endoscopists. But if you know surgical anatomy, you stay away from those structures that can create problems. One very important thing is that you have to understand how deep you're going with your tissue anchor device. You see that here, the tissue comes nicely towards myself. If I have some resistance, it means that I did get something else outside. Usually it's fat, but it could be, if the patient is on the side, the gallbladder, or it could be the bowel. So you really have to be extremely careful when you do this. And this is probably the one important take-home message when you're learning this procedure, from safety-wise.
Silvana, you're making this look very easy, I think deceptively so. What would you tell people that are learning it that they could expect the learning curve to be? How many cases are not going to go quite as fast as this and require some extra attention before they get to your level?
I think that this is not a difficult procedure. I think that there are two things that are difficult. The beginning is trying to, it's like when you're learning how to drive, you have to look at the ahead, and you don't have to look at your hands or at your feet. This is the same thing. You really have to master the device and understand how it works. If you understand how it works, it becomes technically very easy. And usually surgeons understand this pretty well. In terms of orientation, where to place your suture, I think that probably intellectually, that's the most difficult thing to understand in order not only to make it work, but to make it effective. And that is really understanding how, where you're going to place your stitches, how much restriction you're going to give the patient, and how much also shortening of the stomach, which is one of the fundamental part of this procedure you're going to do. So the one thing that I would suggest is really do a lab where you just focus on the technicality of the device. Once you master that, then you can go to ex vivo model. I'm not sure that in vivo models are that useful. And then you should go and see this procedure like you're doing here, but come to an OR and ask somebody to mentor you for the first, I would say, 4 to 5 cases. And that's the ideal way to learn this procedure.
Silvana?
Yes.
We will be connected to one participant who has a question.
Yes.
go ahead. You can ask your question. It's Jose. You can ask your question.
Hello.
You're online.
Hello, Silvana.
Yes.
Good morning
Hi.
from Mexico.
Oh,
how
hello.
much restriction can we cause with this procediment?
How much what? Sorry, excuse me? Restriction.
Restriction.
Yes, I'm going to show you here. You see, I think that you can probably get around 60% of the gastric volume. You see, this is very nice to see in 3D, actually. You see those folds? That, I mean, it gives you a good idea. And if you really want to make sure that you're restricting well, you have to keep your finger on the insufflation in order to stretch the stomach as much as possible. And you see here that we got about 60% of the area that we worked it. But again, restriction is not the only thing. I placed just 2 stitches and already had probably a 30% reduction on the gastric length. So this is also something very important that you have to keep in mind. So you're achieving both, and that is why there have been a number of publications regarding what is the best shape of the stitch. I think every single surgeon and endoscopist has signed his own path, a U, a square, a reverse W. I'm simple. I do a purse ring, which is a very good surgical suture that gives me both restriction and shortening.
Thank you.
You're welcome.
Silvana, Manuel, I fully agree with you. So it is suture. So when we talk about suture, it's interesting because it seems that pretty much every single one of us have his own suture pattern, and we claim that our suture pattern is the best in the world. And it's sorry to say, it's it's very silly to say that. It means that if you're doing what Silvana is doing, so effectively reducing and the greater curvature, doing a fantastic job as you are seeing right now, this is enough. And the other thing is we have a lot of publications right now, especially coming from US and some from Spain, and Silvana also. I know that Silvana is working with the physiologic way to do that and how it works. So it's not just restriction that we are discovering, not Silvana?
Yes, absolutely.
Maybe, Silvana, maybe you can talk a little bit about the functional aspects of this. What does it do to gastric emptying? How does it affect diet?
Yes, so it's shortening the stomach, so it is slowing down the gastric emptying, and that has been very nicely and very elegantly demonstrated by several studies in the literature. I think that it is important to note that, of course, it also adds some restriction, but is a very different restriction as for sleeve gastrectomy. Because you still have a low pressure system, and these patients will not complain, for instance, of gastroesophageal reflux disease as you can have after sleeve. These are patients that can have a much more balanced diet, that can have a diet that is rich in fiber, for instance, everything that can even slow more down the gastric emptying is welcome. There you go, we can go here now. Yes.
Silvana?
Yes.
Another question.
Yes.
From Musa.
Yes.
Musa, you can go ahead.
Okay. So here, while I'm waiting for the question,
so the question is, what is the learning curve of this procedure?
I think we did answer that already, but the learning curve of this procedure is managing the technicality of the device and also understanding the endoscopic anatomy, understanding where you have to place the sutures. Here, for instance, we're approaching the fundus. You can see the different anatomy, endoscopic anatomy. So Margherita is turning the device just twice so that we're sure we're not perforating. And here I'm being a little bit closer and even more careful when I'm pulling the stomach towards myself, because I know the short gastrics are there and I want to tear the capsule of the spleen. So I'm being very, very careful here.
And Silvana, if I may
Yes.
help you answer this question. So when you know that you have complete your learning curve, is just to watch Silvana doing the procedure. When you're able to do your stitches and talk graciously about what you're doing, so it means that definitely you are ready. You are ready. So you see that you are able to answer questions and continues, and pretty much what we see in surgery, you know.
Silvana,
Oui.
another question from
Yes.
Firas. And if Firas can ask his question now.
Yes. Good afternoon from Iraq, Silvana.
Hello. Hello.
Hello. I am asking about this procedure. It is reversible or irreversible. So can we remove the stitches later by endoscope?
Yes, it's totally reversible, probably more than we wanted to, because it really depends on how well you place your suture. But this is something that it's naturally reversible after a couple of years. We have follow-up up to 2 years now, endoscopic follow-up up to 2 years now. And at 2 years, there is still some residual stitches, but most of the stitches are gone. You can cut them if you want to reverse them. You can cut them endoscopically and pull the suture out. And sorry?
Did you did it before?
No, I didn't do it before. And in my experience, probably because they go somewhere else, I don't know. But I had only once happened to me to redo one patient, convert the lady into a bypass because of a failure of an ESG. It was a lady that didn't want surgery as the first step, and she asked for an endoscopic procedure first, and she failed it. And it was a sweet eater. So I warned her that this wasn't the best procedure for her. Be careful, be aware of sweet eaters, be aware of patients who already have a very slow gastric emptying might not be the right option for them. But converting it to a laparoscopic bypass is a piece of cake. It's not difficult. I would recommend to do it under endoscopic control, because you have a better understanding on both sides of a 3D anatomical understanding. And the only risk that you can have is that you can staple onto the plastic part of the cinch. If you staple on the suture, that's not a big deal, not at all. But the plastic bit of the cinch, it could be trapped in your staple line.
Thank you.
Silvana, ça continue les questions. And we have a question from our good friend Marius.
Marius.
Marius, so you can connect yourself.
Thank you very much, Silvana, for this nice demonstration. I have a question. If at the beginning of the experience, have you done it more tighter or a light sleeve, or let's say like this, a light sleeve? And is there any correlation when we are seeing others performing these procedures? They are trying to do it more restriction. Do you think there is any correlation between this attitude and the durability of the stitches?
No, I think that I learned from the two chairs that are here. So I learned, I would say, from the best, and I do it the same way. So they taught me to do it like this, and I've seen that it's working pretty well. So I am not doing looser or tighter. I'm not convinced that if you do it tighter, the stitches will last longer. I think it's just like surgery. If you do it too tight, you create ischemia and tension. So I don't think so. And again, the aim is not just to tighten everything, but also to shrink and shorten the stomach. And be aware also of the fact that we're doing a full thickness suture. So even if you don't see the suture anymore from the inside, you will have a reduced compliance of the stomach anyway. And very often when we go back, and we go back every 6 months for 2 years when we follow up these patients, we will see that in some patients the sutures are gone, but you cannot inflate the stomach because you do have this loss of compliance, probably due to the scarring that was left by the work that we had done previously. So I don't think that the number of suture, I've seen people placing 8, 9 suture with a totally disrupted gastroplasty. I think physiology is the key and physics is the key. The key is don't tighten too much here at the beginning. You will really want to see the pylorus. So you create a lower pressure system, and don't tighten too much coming back, because otherwise a high pressure system will weaken your suture, as we know very well in surgery, and will create ischemia and is not going to do the patient well. So I hope that I answered to your question, but I want to show you a very important anatomical landmark. So you see that we place only 3 suture. With only 3 suture, we already are at the level of the gastroesophageal junction here. Why is that? Because of the gastric shortening. And how do I know where I have to stop? Or for me, there are 2 landmarks. One is the Z line here, so the esophagogastric junction. And one is the fact that when I go inside, if I pull back into the esophagus and I go in, I don't see the fundus. So it means that it took everything but the fundus. So I have a very, very nice sleeve-shaped gastroplasty here.
Silvana?
Yes.
Mohammed has a question.
Thank you.
Yes.
Mohammed, you can connect yourself.
Hello.
Yes. Hello.
Hello. Can you hear me?
Yes, very well. Loud and clear.
Okay. I'm Dr. Naeem Taj from Pakistan. And last year I worked with you and learned some tips and tricks from you and from your Brazilian master. So there's no doubt about your skills and all these things. But my question is that, is it safe to perform these procedures nowadays when this COVID pandemic everywhere and we have kept our hands away from laparoscope and all these things? We are not doing any elective surgeries. So do you think, is it okay?
If it's wise to perform these procedures today, that's what's the question.
Yeah.
Well,
How do you, maybe another way to frame it is, how do you handle COVID and endoscopy? What's your, protocol and philosophy?
Yes, you see that both Margarita and myself are wearing FFP2 or N95 devices, and that is why you might think I have a lung problem. It's not because of that, but it's very difficult to breathe with those masks. That's why I'm breathing heavy. And she's good because she's wearing glasses. I can't see anything, so with glasses, so I should do it, but I don't. And of course, the patient has been tested for COVID. So we are making sure that we take all the precaution. The patient is tested, we are geared up. We step outside when the anesthesiologist intubate the patient. And then, of course, everything is, including the room, is cleaned and disinfected in between patients.
Okay.
If you
Thank
take
you.
So here what I'm doing, I'm just putting an additional stitch, and this is something that is not really needed if you want, but I see that there is a little bit of a gap here. I know that some of the experts don't mind, but it's just aesthetically, I don't like it. It's like a pocket, and this pocket here is not gonna make any difference in terms of restriction, but I just feel like it's better if I close it. So I'm just gonna place, I would say, one stitch to close it.
Yes, Silvana, it's answer a little bit the question of Musa, who was asking about how much of the gastric capacity we have to reduce by this technique.
Well,
Silvana, if I can add to that, can you enlighten us what the beautiful work you are doing in IRCAD and HIU of finally, and I had the opportunity to review one of your papers. That's the work you guys are doing on measuring the gastric volume, because to me it was like measuring like a fantasy, because that never before we are able to measure the gastric volume with the technology we had before. And what you're doing now is a very out of the curve, very advanced. And I think you are, you guys in IRCAD and HIU are the ones who could finally answer to us. How can we help Mohammed to understand that now we can measure gastric volume, and before we are just guessing?
Go ahead. Yes, we did a study, and you're more than welcome to look at it, that has been published on obesity surgery, and we are measuring using dynamic MRI the rate of gastric emptying after sleeve gastrectomy, before and after sleeve gastrectomy, giving patients a test meal. And it is very interesting because it's one of the most accurate way of assessing changes in shape, anatomy, and physiology at the same time. And we're going to repeat the same study with sleeve gastroplasty and compare the results with laparoscopic sleeve. And I think that finally we will have, as Manuel was saying, a very good understanding of what we're doing, because the studies that have been done so far are not as precise and cannot combine anatomy and physiology together as can dynamic MRI. So I am done now. If my chairman agree, I have my sleeve. I'm gonna clean up everything and get rid of all the blood. So this is an operation that will get the patient nauseous. Nausea is one of the worst side effects of the procedure. We're giving antiemetics to the patient at induction and every 4 hours, the first 48 hours, because if they vomit, of course, you can understand that they're going to put a lot of pressure on the sutures. If you have blood cloth or anything that is in the stomach, that could actually facilitate and enhance the vomiting of the patient. So make sure that you have a very clean stomach before leaving. That will allow you also to be sure that nothing is bleeding in there. Although bleeding by experience, it's very rare in these patients.
Silvana, maybe you could talk a little bit about the most common complications and maybe even some of the rare complications that you've encountered, both during the surgery and in the immediate postoperative period.
Yes, the most common complication that well, I think that the most common complication are actually technical complications related to the device. You can have the cinch that can be trapped into the stomach, and that I explained to you how to fix this, to troubleshoot this device. You can have the suture that gets trapped into the helix. You can have actually you can have the needle that is trapped into the tissue, and you won't be able to manipulate anymore your device. And this happens when you see here we have this metallic cable that is around the that is holding the suturing device, and that has to be parallel to the scope. If you have something like this, I'm not going to be able to open correctly my needle holder. So sometimes if you cannot open your needle holder or you cannot move it, it's because the cable twisted around the scope. And careful, because that's a beautiful exemplar way of doing a ESD of the esophagus, stripping all the mucosa, because it's like a razor blade into the esophagus. Other complication is bleeding. You can have a bleeding because of the needle. What do? You just pull onto the suture. If it doesn't stop, you cinch it, as you would do in surgery. You don't need to use epinephrine. You don't need to use a cautery. In 90% of the cases, over 90% of the cases, it stops very well just by pulling. And if it doesn't, you just cinch it and use another stitch. I didn't have any perforation in my experience, but that has been described in the literature, especially at the level of the fundus. So once again, be careful on how you deal with that particular area. There have been inadvertent, I would say, communication with the abdominal cavity and different kinds of organ in the abdominal cavity. It's very rare. And again, if you use this configuration for the patient with the patient supine, and especially if the patient didn't have any previous surgery, that is really, really rare. I would say that those are the main complications that you can have with these procedures, and of course, complication related to the introduction of the blind introduction of the device. I don't know, Manuel, if you have other story to share.
No, pretty much what you said is bleeding during the procedures. You can have it. Perforations. And I will get back to the Marius talk in numbers of suture and how you tighten. And let me tell you this, I was, Silvana, I was called to get into complication of cases. And when we do a root analysis, meaning try to identify what causes that, I can tell you, my friend Marius and Silvana, that most of the times, the one who did the procedure tried to mimic a surgical anatomy in doing a tight sleeve. So it's not just something that can happen, but something that really happens. So if you tighten too much, the pressure will be so much that the sutures can rupture through the stomach and can cause problems. So I will advise that to let it lush, understand the anatomy, and understand that is not really something that you wanted to pursue is as a surgical anatomy, because we want to explain to you that it's physiological is not the same, anatomically not the same. So it's a new procedure that you have to understand, study, and respect.
Silvana, I might
Yes.
pose one final question. Perhaps you can describe to the audience your protocol for taking care of these patients afterwards. How are you going to feed them, advance their diet? And you mentioned this briefly, but what's your follow-up schedule and long-term targets?
So thank you, Lee. This is a very good question. By the way, we just removed, you've seen it before, under control, the overtube, and now Margherita is checking again the esophagus. Always double check the esophagus after removing the overtube to make sure that there is no lesion there and you didn't do any damage, going all the way up to the pharynx. So the patient now, this is an ambulatory patient. Since our 50th case, we started doing this as an outpatient procedure. And once again, we make sure to control the vomiting and to control the nausea, because that's the most important issue in the immediate postoperative period. Very little need for pain medication. This is not a procedure that is going to give a lot of pain. Patients who have pain are probably patients where you went too far with your bite and you grabbed a little bit of peritoneum. If you did that, they will say, I have an abdominal pain. Otherwise, they just feel a little bit of discomfort, like they did a very heavy abdominal exercises and session. I avoid to give them a lot of liquids. I tell them that they're allowed a couple of glasses of fluid the first day, and they can start a liquid diet that they will keep on for 1 week. The oral intake is very similar to what you would do in a sleeve gastrectomy patient, but very much accelerated. You don't need to keep them on a liquid or soft diet for a very, very long time. I think it's counterproductive. I think that very soon you will need to introduce fibers, and you will need to introduce solid foods, because it will contribute to making them feel satisfied and increase their satiety. In terms of antibiotics, just a single shot at induction. We don't use any other antibiotics in the postoperative course. We do put them for 6 weeks on PPI, 40 milligrams. I see them, as I would say, my bariatric patients. I see them at 1 month, 3 months, 6 months, 9, 12, and then every 3 months, basically. And we do endoscopy, as I mentioned before, at 6 months, 12 months, 18 months, and 2 years after the procedure. And that has been extremely useful, because we are just submitting a paper showing that there is no change in the esophagus, stomach, or duodenum from an endoscopic, macroscopic, and microscopic side in terms of before and after the procedure. So it's a procedure that it doesn't change the anatomy. Macroscopically, of course, yes, but microscopically, nothing happens. You don't have more cancer, you don't have more esophagitis, you don't have more Helicobacter pylori. So we're not interfering with the environment with this procedure.
Silvana, no, we're coming progressively to the end of the session because video conferencing has to be short. We just give the ground to the participants. So the participants who want to ask a question, you have just to activate your microphone and you'll be online. No question?
Maybe while we're waiting, Silvana, I'll ask one more question. How do you select patients to offer this? Because you do as well bypass sleeve gastrectomy. So is there a BMI category to do it, a type of eating that you would offer it to?
Yes, I think this is a procedure that suits very well lower BMI patients, patients that have a BMI around 35. Unfortunately, here in France, we have a hard time including patients from 30 to 35, but those are really the ideal patient because it works very well for them, the procedures. So my experience is a little bit skewed because we had the worst case patients. I think I have the world worst case series because at the beginning, I would receive only patients that nobody else wanted to do. So patients who had multiple comorbidities, too frail to undergo surgery, who had multiple pre-operation with a frozen abdomen, or extreme super obese patients with BMI very high. So I have a wide experience, and I can tell you that it's a procedure that can work very well. I would recommend it to patients who are lower in BMI, so around 35, less than 40, I would say. Patients who do not want surgery as a first step, patients who cannot undergo surgery because they're too frail, or they had some anatomical modification that will not allow them to have laparoscopic surgery. I would stay away from sweet eaters and frequent eaters. Those are my main contraindication for these procedures. But it's something that as a first step, can work very well with any kind of patient.
Great.
Questions from the audience? Again,
yes,
you can.
Can you hear me?
Yes, okay.
So I have a question that if the patient had a endoscopic sleeve gastroplasty, is it safe to perform sleeve gastrectomy in that patient? And also any precaution for that patient? And
yes.
If the patient had gastroesophageal reflux disease, so can you safely perform this endoscopic sleeve gastroplasty in that patient?
So there are two questions. I'm not the right person to answer your question regarding the sleeve because I'm not, as Manuel and Lee know, a big fan of sleeve gastrectomy, being a functional upper GI surgeon. But yes, it is possible. But once again, I would recommend to do it under endoscopic control so that you don't staple on the cinch, on the plastic part of the cinch. Does it make sense? Because we are already doing a restrictive procedure. Does it make sense to go from a gastroplasty to a sleeve, surgical sleeve? I don't think so. And I'm not, I tell my patient that if we have to do surgery, I'd rather offer a bypass than a sleeve. But that is my own take. If you're asking if technically it is possible, yes, it is possible. Then gastroesophageal reflux disease. We did study our patients in terms of gastroesophageal reflux disease, and we did not see any increase in gastroesophageal reflux disease. Patient who did not have GERD didn't develop GERD. Patient who had GERD before the surgery, they either had no change or they improved their gastroesophageal reflux disease. We're not creating, once again, a hyperpressure stomach, a pressurized stomach. We are not interfering with the anatomy. We're not taking down the His angle. We're not working around the hiatus. This is a procedure that I've done also in patients who had small hiatal hernia with no aggravation of their gastroesophageal reflux disease if a GERD was present before surgery.
So, Silvana, if I can be at help with these questions about how, if it can be converted to a sleeve gastrectomy. Well, there is at least 8 papers that refers to conversion from endoscopic sleeve gastrectomy to sleeve gastrectomy. It's very interesting to see, because some of the papers say, oh, this is very difficult, we have to put endoscope and guide that. But then they describe the technique, it's easy and no problem. And a more fair judgmental one is they say, just put the scope, look at the sutures, and understand where your staple gonna be. And there's a very recent publication that say, you know what, you don't need anything, that go there and staple. Because the way that this procedure was designed is to be upgraded to a surgical procedure in the future, because it's a chronic evolving disease.
Thank you very much. Thank you. This was very informative sessions. Thank you.
Silvana, when you do see these patients, you scope them quite frequently. Do you ever add sutures later if they plateau and start regaining weight?
Yes, when I see these patients preoperatively, I tell them that this is a procedure that can be performed again, if necessary, and that is mainly according to their BMI. When I scope the patient at 6 months or 1 year and they're still over 30 BMI, I tell them that I can place additional suture. That is totally doable. We do it pretty often. We're now starting a randomized trial in order to really assess the role of redo or retighten gastroplasty to see what is the advantage of doing that, because of course it adds a lot of additional costs.
And Lee, if I may, and please don't kill the messenger, it's coming from your original country. So I just got an advertisement of endoscopic sleeve gastroplasty that they are selling the packages solo and with resuturing. So 100% guarantee. So it's maybe is a way to see that also. So it's feasible. You can do it 2-3 times. My maximum was 3 times in a patient that have done before 2 out, and the patients wanted to keep that. So it's really, you can do fine touching, you can redo it. So technically it's very feasible.
I imagine you wouldn't do it in a case where they just didn't lose very much weight after the first time, and probably reserve it for patients that did well in the beginning and then start regaining.
Yes. So I don't do it if the patient doesn't comply to the nutritional advice and doesn't come to see me or see the nutritionist and follow up. I don't do that. I tell them right at the beginning. That's a key element for me. Compliance.
Okay. Other question from the audience? Take your chance, because we're coming to the end of this session. No question. I'm just watching the screens. No question. So thank you very much for being with us. I have a final message from the organization, is that for the live session, which will include lectures tomorrow, you don't need to register again. You will receive an email with the link, because you need a new link for the lectures. And we will also propose some short survey to have your opinion, your feelings about this live session. And if you want to comment what we should do or not do, you're free to do it. It's the meaning of this interaction. And of course, to finish, if you like this sort of procedure, you can always connect to WebSurge, because we have a lot of different live pre-recorded demonstration by Silvana, Manuel, Lee. So you can enjoy that in WebSurge. And just to remind you that WebSurge is totally free. So you have just to create an account and you can connect and watch the videos that you're willing to do. So Silvana, a final word?
No, thank you very much. For me, it's been a pleasure. I hope that has been a pleasure for you too. I'd like to thank my chairman and Bernard, and of course, Margarita, who's taking care of the patient. Thank you very much. Hope to see you soon.